Hello, I'm Dr. Jonathan Silverberg. I'm an associate professor and director of clinical research and patch testing at the George Washington University School of Medicine and Health Sciences in Washington, D.C. And today I'll be discussing Dupilumab-associated facial skin changes. So let's start first with how commonly does facial erythema occur with Dupilumab? And a recent systematic review examined the literature, and really the literature right now is sparse. Only 101 patients were identified from 16 studies that were reported to have Dupilumab-associated facial or neck erythema. Of those, 52% had baseline atopic dermatitis involving the face or neck. 11% discontinued Dupilumab owing to this adverse event. Now, that's probably an overestimate of how many in the real world will really discontinue for this indication, but it shows that there are patients who are stopping because this is a bothersome problem. And it's been reported to have multiple potential etiologies: rosacea, allergic contact dermatitis, facial flushing from alcohol, head and neck dermatitis, as a broad sort of terminology. Now, it's important to note, though, that facial erythema was not reported as an adverse event in the Dupilumab clinical trials. So we really don't have high quality evidence to know the prevalence or incidence of face and neck erythema in patients treated with Dupilumab. Now let's talk about some of the individual indications or etiologies, I should say, for face and neck erythema. So I'll start with one case series, and this is a case series that I had the privilege of taking the senior position on, and from my own clinical patients. And it's a case series of including 7 adults with longstanding atopic dermatitis, generalized refractory disease. And they were treated with Dupilumab on the on-label dosing in the United States, and all experienced clear skin by 4 to 16 weeks, but had some persistent localized dermatitis that was refractory to Dupilumab and concomitant mid to superpotent topical steroids. And the recalcitrant lesions were localized in a few different areas, but 5 cases of recalcitrant lesions on the face and neck. Now, of these cases, including the head and neck ones, in all 7 cases, at least one positive patch test reaction was observed on patch testing, and with a total of 25 different allergens having a 1+ or stronger reaction. And the allergen sources, particularly for the head and neck, were personal care products that were really the source for all those cases. There were other sources for the non-head and neck cases. And in one case, we even found that repeat patch testing had false negatives. And so that's an interesting implications for using Dupilumab during patch testing. But it also illustrates that for some of the patients who are having persistent facial dermatitis, that some of this may be contact dermatitis. And there's many other case series out there that have shown this as well. For rosacea, there's several studies that have examined this pattern, and one real-world study of 94 Austrian atopic dermatitis patients on Dupilumab found new-onset rosacea-like folliculitis as an unexpected side effect in 6% of patients with a wide range of onset. They also observed increased number of Demodex mites in the follicles. And a quote from that paper is, all patients with rosacea-like lesions also suffered from blepharitis and or conjunctivitis with various intensity. So we often see this head and neck erythema overlapping with some of those ophthalmic adverse events. Now let's talk about alcohol-induced flushing. So this is a fascinating case report, but I need to reiterate, it's just a case report. We don't see this, at least with any regularity, at least I don't see this with any regularity. But of a 19-year-old female with atopic dermatitis since childhood, the atopic dermatitis improved with Dupilumab, but after 16 weeks, she reported new onset flushing of the face and neck 3 to 4 minutes after drinking alcohol and lasting about 30 minutes. And it occurred with different sorts of alcohol. These images were taken approximately 4 minutes after drinking red wine. Really fascinating case. Again, it just illustrates the heterogeneity of the face and neck erythema that seems to occur with Dupilumab. Now, there's also these more seborrheic dermatitis, psoriasis, sebo-psoriasis-like spectrum of reactions that can occur in patients. This is one case of a 39-year-old man with atopic dermatitis since childhood. And the patient developed after several months of Dupilumab, the painful and itchy facial lesions that didn't respond to TCS. And on photo A is while they're on dupilumab before there was any additional intervention taken, and panel B is taken after 3 weeks of oral itraconazole. And so the authors have suggested that maybe this is more in the Malassezia yeast family, and that's why itraconazole is an option. But we have to be careful about that interpretation, because we do know that oral itraconazole comes with systemic anti-inflammatory effects. So how much of the improvements are really from those systemic anti-inflammatory effects versus the anti-Malassezia effects? And I think this is a debatable point that will require further investigation. Now, I want to review my own personal experience, because it really illustrates the heterogeneity of what we're up against when we are evaluating patients with dupilumab, what is labeled dupilumab facial erythema. So this is a middle-aged woman who was on dupilumab for many months, was actually prescribed by another prescriber before she ever saw me, and pretty much clear from head to toe, or from neck down, I should say, and said that dupilumab was a miracle for her. But the face didn't get better. And not only that, if anything, she thought it got worse on dupilumab. Well, it turns out we patch tested her. She tested positive to sorbitan sesquioleate on an extended series. And and even though this was someone who was refractory to super potent clobetasol, topical steroids, clobetasol under occlusion didn't help. And then we eventually found the positive patch test. It was present in her foundation and blush, and the lesions at least improved somewhat with on follow-up with the allergen avoidance. Now, here's another case to think about. So this is a young lady who did spectacularly within about a week of going on dupilumab and had improvements on dupilumab better than cyclosporin was able to accomplish at a higher dose, but came back with conjunctivitis, which you can't see her for de-identification purposes, and this facial erythema approximately 1 month later. And we weren't initially sure if it was from the dupilumab. What she said was she felt it was sort of like her seasonal allergies, but the worst they had ever been. And so that's one pattern where it's more of what looks like an eczematous, spectrum, ill-demarcated light pink lesions that were quite itchy. This is an adolescent who had no pre-existing atopic dermatitis on the face ever. And dupilumab worked beautifully for the neck down, but she presented with these burning hot, very uncomfortable, bright red, blotchy and more well-demarcated lesions on the head and neck area, even including the ears, very uncomfortable, and in the end required discontinuation of dupilumab because nothing really was able to stop it. It was so refractory. This is a middle-aged gentleman that never really improved with dupilumab at all. He had pre-existing facial erythema, pre-existing ophthalmic involvement of eyelid dermatitis, and felt that the dupilumab may have actually worsened his seasonal allergies and didn't really improve the overall disease. So I don't know if I would call this dupilumab caused facial erythema versus it just didn't respond to dupilumab. And we have to include that in our differential. This is a middle-aged woman who did very well overall with dupilumab therapy, but had this more ill-demarcated lesions on the face. You can appreciate the lichenification, the angulated erosions from scratching. This was very itchy and uncomfortable. She also had profound conjunctivitis, maybe even a component of keratitis and eyelid dermatitis as well. This is I think a pattern that I see quite commonly, someone who had very profound, as you can see, eyelid involvement, but also on the forehead, these more well-demarcated, almost purplish, almost like the color of connective tissue disease lesions, super refractory to topical therapy, just don't budge with anything. This is another young lady with profound eyelid involvement, but a more generalized, subtle, light pink eczematous reaction. This is someone with a more of that sebopsoriasis-like pattern, less scaly in this particular photo, but involving the scalp, the posterior neck, a lot of scale involved at different times and different stages, also very refractory to therapy. This is someone with a more acneiform pattern. And you can appreciate the more discrete, distinct lesions These were not particularly itchy, and it was more of a rosacea-like pattern. This is someone with much more of a flushing-like situation, not related to alcohol, but just that heat and redness and just almost like urticaria, rapid onset erythema that would occur. It's another gentleman with more persistent refractory, sort of hybrid rosacea-like scenario. And this I just threw in for the fun of it. This is someone who, you look at this and say, oh, that looks like dupilumab facial erythema. This is someone before they ever went on dupilumab, whose face completely cleared. I don't have the after photo displayed here, but whose face completely and totally cleared. So let us be clear in our discussion of this that dupilumab, works beautifully for many face and neck erythema cases, but we have this paradoxical reaction that can come up. So how do we assess facial erythema? Good history and review of systems. Check if there's a baseline history of ocular disease or facial lesions. Look for the temporal relationship with dupilumab. Is it episodic or chronic? That'll dictate what treatment types you might need. Is it secondary to withdrawal of topical steroids or oral steroids or calcineurin inhibitors like cyclosporin? Very important from a bridging therapy perspective. Careful examination. And I think this is most important. If the morphology is acneiform, treat it acnea-like. If it's eczematous, treat it eczema-like. If it's psoriasiform or sebderm-like, treat it in those approaches. And usually your clinical skills as a dermatologist can guide this. Supportive testing is sometimes helpful. Patch testing to rule out airborne or allergic contact derm, prick testing to rule out environmental or protein allergens, and biopsies or histopathology have really not been useful in my practice, but you might consider them in refractory cases. And then for treatment, think about known allergen avoidance, trial of topical steroids or calcineurin inhibitors, topical rosacea treatments in cases that look like rosacea. Oral steroids are generally very effective, but I wouldn't recommend them because they're not a great long-term solution. Topical anti-yeast and antifungals have not worked at all in my hands. I know other centers have had better experiences. And then oral antifungals or antibiotics seem to work, but unclear why. And then, of course, you can consider tapering the dupilumab to maybe every 3 weeks or every 4 weeks in patients who are clinically almost clear. And with that, I'd like to thank you for your attention.